So, welcome you all in our second session of NHF course on cardiology. As you all know, in such a very difficult situation, we are all actually physically distant with each other, but definitely we are socially connected. And through this social connection, our today's lecture is on mitral regurgitation. We have got 4 excellent learned speakers today who will share their knowledge with all of us. Dr. Mir Ishraquzzaman, and Dr. Associate Professor Dr. Mir Nesaruddin Ahmed, Associate Professor Dr. Muhammad Kabiruzzaman, and Professor Nazir Ahmed. So let's start. Our first speaker will be Dr. Mir Ishraquzzaman. He will be talking about etiology and pathophysiology of mitral regurgitation. Dr. Ishraquzzaman, the floor is for you.
So respected moderator, teachers, colleagues, seniors, juniors, and attendees, Assalamu alaikum, and very good afternoon. So can you hear me, please?
Yes. Okay.
Yes. So I will have a talk on etiology and pathophysiology of mitral regurgitation. Mitral regurgitation occurs due to abnormal systolic regurgitation of blood from the left ventricle to the left atrium and results from incomplete mitral valve closure and a pressure gradient between left ventricle and the left atrium. Mitral valve leaflets, mitral annulus, chorda tendina, and papillary muscles comprises the mitral valve apparatus. Each of the valve leaflets, like posterior valve leaflets, had 3 scallop parts designated as P1, P2, P3, and the corresponding part of the anterior leaflets is designated as A1, A2, A3. Anterior portion of the mitral annulus is in the continuity with fibrous skeleton of the heart, making it less prone to dilatation than the posterior annulus. So normal function of the apparatus brings both leaflets together in systole, creating the coaptation zone, and which located in the posterior 1/3 of the valve orifice. Valve leaflets are attached to the papillary muscles through chorda tendinae. It should be mentioned here the anterolateral papillary muscles receives dual blood supply from the left anterior descending and circumflex artery, where the posterior medial papillary muscle is supplied by the right coronary artery or left circumflex artery, depending on the coronary dominance. So mitral regurgitations can occur as a result of malfunction of the component of mitral valve apparatus. So clinically, mitral regurgitation can be classified as primary MR and secondary MR, and secondary MR can be further classified as ischemic causes and non-ischemic causes. And depending upon the type of onset, it can also be classified as acute and chronic MR. These are the most common causes of acute mitral regurgitation, like myxomatous degeneration, rheumatic heart disease, coronary artery disease, infective endocarditis, acute global left ventricular dysfunctions due to myocarditis, trauma, if tear occurs during the PTMs or valve heart surgery, infiltrative diseases, systemic lupus, erythematosus, and atrial myxoma are the rare causes of acute mitral regurgitation. Causes of chronic primary MR are rheumatic heart disease, degenerative mitral valvular disease, coronary artery disease, infective endocarditis, hypertrophic cardiomyopathy, calcification of mitral valve annulus, congenital such as mitral valve clefts or fenestrations, and paravalvular prosthetic cleft. And in the secondary chronic MR, dilated cardiomyopathies and aneurysmal dilatation of right ventricle are the main causes. So let's look at the few diseases which causes MR, like myxomatous degeneration of the mitral valve. So hooding, we can see the hooding of the prolapse of the posterior mitral leaflet in the left atrium, which can cause a mitral regurgitation. But in acute case, if their rupture occurs, it leads to the acute mitral regurgitation. This is a classic picture of mitral valve in the rheumatic heart disease with leaflet thickening, shortening, thickening, and fusion of tendinous chorda and typical fish mouth appearance. When tear occurs in the chorda tendina, it results in acute mitral regurgitation. It should be noted here in acute rheumatic fever, though we will discuss it in another session. In acute rheumatic fever, carditis is the main cause of mitral regurgitation. We can see the picture of mitral valve leaflet in the infective endocarditis. Vegetation, we can see here, it often interrupts the valve closure. There is perforation, which results in mitral regurgitation, and abscess formation cause mitral annular disruptions, and the papillary muscle rupture and chorda tendina rupture due to infective endocarditis also cause in acute MR. When the ischemia is a cause of mitral regurgitation in the acute setting, most commonly occur in the inferior posterior MI, as I have noted before, that posterior middle papillary muscles is supplied by the single blood circulation with RCA or LCX. So papillary muscle ruptures or chordal avulsion can cause mitral regurgitation in acute setting, though the complete papillary muscle ruptures lead to death if not taken intervention in the rightly time. An altered LV geometry causing papillary muscle displacement, elongation of the infarcted papillary muscles, and exaggerated contraction of the non-infarcted papillary muscles results in acute mitral regurgitation. In the chronic mitral regurgitation, papillary muscle necrosis and segmental dysfunction of inferior posterior wall causing leaflet tethering and poor coaptation. MV closing forces decreases due to systolic dysfunctions, and LV cavity dilatation causes mitral valve annular dilatations, which results in chronic mitral regurgitation. Mitral annulus normally 10 centimeter in circumference. So with sufficient dilatation, loss of adequate leaflet coaptation, and tethering of leaflet and chorda can occur and produce relative restriction of leaflet motion. In the hypertrophic cardiomyopathy, we know that systolic anterior motion of the leaflet occurs due to the Venturi effect, results in mitral regurgitation. Causes of mitral regurgitations are categorized by the mechanism of leaflet dysfunctions or motions in the Carpenter's classification, which really helps to determine the strategy for surgical intervention. So these are the classifications. So type 1, when the leaflet is in normal motion; type 2, with increased leaflet motion; type 3A, restricted leaflet motion in systole and diastole; and type 3B, when the restricted leaflet motion is only in the systole. These are the causes according to the type of the leaflet motion in the Carpenter's classification. So let's look at the pathophysiology of mitral regurgitation. In acute MR, left ventricles and left atrium are unprepared. So there is sudden increase of left ventricular end diastolic volume. Thus, preload also increases, and according to the Frank-Starling mechanism, stroke volume also increases. As there is incompetence of the mitral valve orifice, so there is increased regurgitant volume to the LA. So as I told, that left atrium is not prepared to receive such a large volume. So eventually pulmonary congestion occurs, and the patient presents to us with a complaint of acute dyspnea. Because of the regurgitation of the blood volume from the left ventricle to left atrium, forward stroke volume also reduces and reduces after load. So thus, the low cardiac output syndrome may occur in the patient. So patient may present with hypotension and cardiogenic shock. If the patient tolerates this phase, then it enters to the compensated phase of chronic mitral regurgitation. Over time, left atrium and left ventricle receives more blood volume. So thus increase in left ventricle end diastolic pressure and left atrial pressure, and compensatory of the left atrium and left ventricle helps to accommodate volume load at lower pressure. So, and it also reduces the pulmonary venous pressure. And it should be mentioned here that during diastole, left atrium also empties its blood volume to the left ventricle. The eccentric left ventricle hypertrophy stimulated by left dilatation further according to the Laplace law. So the total stroke volume increases to maintain the normal forward stroke volume. But during this period, patient may enjoy their life, but as the time goes on, mitral regurgitation begets mitral regurgitation. It's a vicious cycle of further left ventricle and annular dilatation causing more mitral regurgitation. Eventually, contractile dysfunction ensues and ejection fraction reduced, end-systolic volume increased, and thus pulmonary congestion and pulmonary hypertension develops. And there is also reduced forward stroke volume and cardiac output also reduced, and the patient developed the syndrome of low cardiac output. Staging is very important for the management plan of mitral regurgitation. So there are 4 stages in primary or secondary MR. This is at grade A. This is at risk of MR, grade B, progressive MR, grade C, asymptomatic severe MR, and symptomatic severe MR. So if we look by phase to phase, or by stage to stage, we can see the grade A who are at risk of MR. We can see the valve hemodynamics. There is no MR jet or small central jet area less than 20% left atrium on Doppler, and small vena contracta less than 0.3 centimeters. In grade B, which is progressive MR, central jet MR 20% to 40% left atrium, or late systolic eccentric jet mitral regurgitation, vena contracta less than 0.7 centimeter, regurgitant volume less than 60 ml, regurgitant fraction less than 50%, and effective regurgitant orifice is less than 0.4 centimeter, and angiographic grade 1 to 2 plus. There is a little mild left atrial enlargement, though there is pulmonary pressure is normal. In asymptomatic severe MR, we can see central jet MR is more than 40% of left atrium, or holosystolic eccentric jet mitral regurgitation, vena contracta more than 0.7 centimeter, regurgitant volume more than 60 ml, regurgitant fraction more than 50%, effective regurgitant orifice more than 0.4 centimeter, angiographic grade 3 to 4 plus, and moderate or severe LA enlargement is there, LV enlargement is there, pulmonary hypertension may be present at rest or with exercise. And the symptomatic severe MR, all as previous, with angiographic grade 3 to 4, and the patient already has pulmonary hypertension. In the secondary chronic MR, the patients who are at risk of MR grade A, they have normal, no MR jet or small central jet area less than 20% LA on Doppler, and small vena contracta 0.3 centimeter. Normal or mildly dilated LV size with fixed or inducible regional wall motion abnormalities may be seen. Primary myocardial disease with LV dilatation and systolic dysfunctions may be present. In grade B or progressive MR, we can see effective regurgitation orifice is less than 0.2 centimeter, regurgitant volume less than 30 ml, and regurgitant fraction less than 50. There is regional wall motion abnormalities with reduced LV systolic function, LV dilatation, and systolic dysfunction due to primary myocardial disease. And grade C is asymptomatic severe MR, ERO effective regurgitant orifice more than 2 centimeter, regurgitant volume more than 30 ml, regurgitant fraction more than 50% with regional wall motion abnormalities with reduced LV systolic function. There is LV dilatation and systolic dysfunction due to primary myocardial disease. And the symptomatic severe MR, ERO is more than 2 centimeter, regurgitant volume is more than 30 ml, and regurgitant fractions more than 50%. There is regional wall motion abnormalities with reduced LV systolic function, LV dilatation, and systolic dysfunction due to primary myocardial diseases. Though it will be discussed in the echo, so I should stop here. So thank you all.
Okay, thank you, Dr. Ishraquzzaman, for your beautiful presentation. You have some question. Do you want to answer now, or you want to answer later on?
Okay,
there
sir.
is a question. Okay, the
Yes,
question
sir.
is, what is the mechanism of pulmonary hypertension in MR?
Okay.
And number 2, why ischemic MR is more common in inferior MI? And why posterior part of the mitral annulus is more prone to dilatation? So you have 3 questions, and you can answer one by one.
Okay. I think I have already mentioned in my slides that mechanism of pulmonary hypertension in MR, actually pulmonary hypertension in MR develops slowly than mitral stenosis. As I've already mentioned, that the mechanism of pulmonary hypertension is due to the backflow of the blood volume from the LV, then to LA, and to then the pulmonary circulation. The important thing is here that when the LA become compliant to take the more volume from the LV during diastole, it also helps to reduce its volume to the LV. That's why pulmonary hypertension here develops slowly than mitral stenosis. So I think I answered this question. And the ischemic MR is common in inferior MI because posterior medial papillary muscles is supplied by the single circulation. So left circumflex or right coronary artery. So inferior MI, which is related to the RC and LCX territory, depending upon the dominance of the coronary. So that's why ischemic MR is more common in inferior MI. And the mitral, and about the mitral annulus, I have already mentioned there that anterior part of the mitral annulus is continuity of the fibroskeleton of the heart. That's why it makes it less prone to dilated than posterior part of the mitral annulus.
Thank you very much, Dr. Ishraquzzaman. Our next presenter is Dr. Associate Professor Dr. Nesaruddin.
It's okay. Good afternoon, ladies and gentlemen, honorable moderators, my senior and junior colleagues, and distinguished attendees. My presentation is here. Symptoms of mitral regurgitation are usually subtle, and its progression may be insidious, and patient may have self-limit their physical activity, so they are really be asymptomatic for a long time. So if we consider the symptoms of chronic MR particularly, patient usually remain asymptomatic for years to months to year, and usually present with initially fatigue or palpitation, and sometimes patient may have normal physical exercise tolerance until systolic function of the left ventricles develops, and sometimes dyspnea on exertion, usually on first of all exertion, then shortness of breath, and ultimately patient develop PND and orthopnea. And sometimes patient may have right-sided heart failure that is included the dependent edema, ascites as well. And if we look at the acute MR, as because it is acute and heart is not ready to compliance with this volume, patient usually initial part, patient usually present in the CSU setting or other setting, acute setting, patient dyspnea and orthopnea is more common than other symptoms, that is fatigue and palpitation. And if you look at the physical findings for the mitral regurgitation, especially in chronic case, apex usually downward and outward and forceful and ill-sustained due to LV dilatation and hypertrophy and as well as regurgitant lesion. And there may be systolic thrill in the parastral area and also parastral heave due to right ventricular dilatation and hypertrophy, and the palpable pulmonary artery and as well palpable P2 also. And that is if you look at the jugular vein, they may be raised and there may be V wave, and there is hepatomegaly and hepatojugular reflux as well, and there is pedal edema. And if we look at the basal part of the lungs, it was a basal occupation as well. But characteristically, there is a normal blood pressure and good volume of pulse of the patients, particularly these patients. And if you look at the acute MR, usually the clinical background is very important. It's a sudden onset and usually decompensated stage. And patient usually having severe breathlessness, and sometimes we have pulmonary edema and basal occupation. And the characteristics of the patient have tachycardia and tachypnea. But if you look at the different diagnostic models, that is ECG or chest X-ray, and here the characteristically heart size will become normal, but murmur usually soft or absent, and maybe ejection quality and it's to the base, and S2 is widely spread due to early A2. Apex and usually reduce toward the axilla, and we hand grip exercise reduce the pulse and the valsalva, and S1 usually absent, soft, and S3 particularly in sudden testing of the pupillary muscle and silhouette, and there's mid-diastolic flow murmur without mitral stenosis, and in severe case that is S4 as well, and in severe MR the holistic murmur which is decrescent in nature. And in chronic mitral regurgitation and systolic murmur usually in grade 3 by 6 intensity minimum grade, that is, and usually hollow systolic, and in acute severe case the decrescendo and seizure in mid to late systole. And on sometimes we can do some maneuver, especially when asymptomatic cases on heart murmurs remain silent. In that case, we can do the leg elevation or isometric exercise. And in case of mitral valve prolapse, the mid systolic or systolic murmur and systolic clicks, and it can be accentuated with squatting and hand grip. And sometimes we need to dynamic auscultation. That is, what does it mean? It means to alter some hemodynamic parameters during cardiac auscultation in order to diagnose the etiology of a heart or murmur, heart sound or murmur. And what are the different modalities for dynamic auscultation? We can involve in that patient, particularly auscultative patient in respiration, changing, postural changes, valsalva maneuver, isometric exercise, or producing premature ventricular contraction, or can use some pharmacological agent, that amyl nitrate, methyl phenylphenols. And there's the effect of murmur, especially in mitral valve prolapse, the mid-systolic click and systolic murmur you can have earlier during inspiration, as because inspiratory reduction in the LV size and increased redundancy of mitral valve, and there is mitral valve prolapse. And here is the scene of the systolic comes towards the SM faster sound in case of inspiration and becomes delayed in case of during expiration of mitral valve prolapse. And LV volume is decreased, so there is standing and valsalva. And on the other hand, LV volume on auscultation, there is a hollow systolic murmur is present and prominent is increased. And what the differential diagnosis? First of all, should think about a mitral valve prolapse. Then we can think about especially calcified aortic stenosis, which is causing prominent murmur at the apex, and may be confused with the mitral regurgitation hollow systolic murmur. And there is functional TR, maybe also left lateral sternal border, and but it is not related to the axilla and increased intensity in inspiration. And sometimes VSD may be confused with the mitral regurgitation, so causing heart's hollow systolic murmur at the left lateral sternal border and radiate to the right of the sternum. And papillary muscle dysfunction, as already Dr. Ishraquzzaman already described, and especially posterior middle papillary muscle dysfunction, as because it is supplied only by either RCA, right coronary artery, or left circumflex artery. And in case of ASD, there is causing wide and fixed spreading murmur, so there is no confusion with the mitral regurgitation, and sometimes traumatic, especially during after post mitral valvotomy. There is the differentiation of valvular lesion in case of
ইনভেস্টিগেশন এর মধ্যে কিছু প্রশ্ন আছে তাও ঠিক হয়ে যায় কিনা। প্রশ্নের মধ্যে একটা আসছে যে হোয়াট অ্যাবাউট দ্য পালস ইন সিভিয়ার এমআর, ইজ ইট স্টিল ইন গুড ভলিউম? মানে সিভিয়ার এমআর এর পালসের কি ক্যারেক্টারিস্টিক ভলিউম কেমন থাকবে?
Especially in the mild to moderate cases, there is a good volume of pulse and blood pressure as well as normal blood pressure. But when patient develop LV dysfunction, in that case, and some gradually become low volume pulse, and is depend upon the output of the LV.
আরেকটা প্রশ্ন হচ্ছে হাউ উইল ডিফারেন্সিয়েট দ্য কজ অফ এমআর বাই রেডিয়েশন অফ দ্য এমআর? ক্যান ইউ ডিফারেন্সিয়েট এমআর বাই কজ অফ দ্য এমআর? মানে রেডিয়েশন দিয়ে দেখে কি কজটাকে বোঝা যাবে কিনা?
Mitral usually most common cause in our country, that is rheumatic valvular heart disease. It is usually associated with metastasis as well. And sometimes, yes, we can differentiate either it is ischemic or it is a primary MR. If it is ischemic, in that case, it may radiation, particular radiation is toward the either toward the axilla or toward the base of the heart. In case of particularly for ischemic MR. And for rheumatic valvular heart disease, in that case, particularly radiation toward the axilla.
And
Can I
arthrosis,
add something? Can I add?
Yes, sir.
yeah.
Why not?
Actually, I think he wants to know, according to the prolapse of the mitral valve, whenever there is prolapse of the anterior leaflet, the MR jet goes posterior. That usually radiates towards the axilla and towards the back, and even some authors say that it can radiate up to head. And whenever there is prolapse of the posterior leaflet, the MR jet radiates towards the anterior view, and this mitral regurgitation may mimic the murmur of the aortic stenosis. That we can differentiate that whether there is prolapse of the posterior MR or prolapse of the anterior MR according to the radiation of the murmur jet. Thank you.
Sir, এখন রান করে
রান করছে, okay.
And different like that is the parasystolic murmur, especially mitral regurgitation. Again, the TR, VSD, and papillary muscle and mitral valve prolapse is the most common, especially for the female sex, and this is due to microtus degeneration of the mitral valve, already told by the our first speaker. And here the systolic click is the hallmark for the diagnosis of the mitral valve prolapse. And how can we judge the severity of the murmur? By the presence of systolic thrill or pansystolic murmur over the mitral area, and presence of S3 and mid-diastolic flow murmur over the mitral area, and degree of LVS seen as clinically and on the ECG and the chest X as well. And some relevant restriction we can do for the diagnosis, that is electrocardiogram, chest X-ray, echo, different models of echo, that is, and cardiac MRI and CT also as well, and stress test, and some sorts of cases that we can do cardiac catheterization as well. And the ECG usually it may be non-specific, or sometimes maybe sinus rhythm, or maybe atrial fibrillation, or maybe volume overload, or maybe left axis deviation or right axis deviation, or as well as right ventricle hypertrophy also. And function may be caused by altered by other concomitant heart disease also. If patient have hypertension or ischemic heart disease, and in case of aortic valve disease, there is a right ventricle hypertrophy, maybe have bundle branch block or arrhythmia, any source of arrhythmia, especially most common atrial fibrillation or some subactive beat also. And left atrial enlargement, this is the, you can see the ECG by right atrial enlargement and left atrial enlargement. And here is the normal, this is the left atrial enlargement, the broad bifid P wave, and this is only right atrial enlargement. Due to delayed activation of the left atrial, there is a notch in the P wave, and P wave duration is usually more than 120 milliseconds. And obviously, we have negative P wave and lead V1 support the diagnosis of left atrial abnormality. And here's the volume overload ECG, and with the volume overload ECG. And chest X-ray usually find the state of the left heart border and double contour of the right border of the heart, and the displaying of the carina and elevated main bronchus, and with the usually prominent pulmonary venous transverse pressure by fissure due to Carlis B line and double for the right border. Here is the typical X-ray for mitral regurgitation, especially acute mitral regurgitation. This is the acute case. And cardiac MRI and CT, when it provides complementary information regarding echocardiography in patient with mitral regurgitation, and particularly is highly accurate for quantifying the degree of mitral regurgitation, and sometimes depict the mitral structure and morphology, especially when planned for mitral repair, valve repair. In that case, it should be go for cardiac that computed tomography. And also it provides true volumetric measurements of the chamber dimension and function, as also as a mitral fibrosis. And stress test usually for the assessment of functional status and symptomatic elicitation. And sometimes stress echocardiography may reveal elevated pulmonary artery pressure and worsening mitral regurgitation. And blunted left ventricular volume and right ventricular contractile reserve as well. And in some cases, we can do cardiac catheterization, especially when planned for, we think about that is a patient may have ischemic origin. In that case, patient definitely go for coronary angiography or sometimes left ventriculography for hemodynamic measurements, especially for non-invasive test in call to sleep, or when pulmonary artery pressure is out of proportion to the severity of the mitral regurgitation as assessed by the non-invasive testing. And sometimes there is conflicting regarding the severity of the MR. In that case, we should go for cardiac catheterization as well. And some complication, patient may develop pulmonary edema, that is medical complication, or congestive heart failure, or irreversible left ventricular systolic dysfunction, thromboembolism. Usually is more common in mitral stenosis, but in case of MR, patient already may develop thromboembolism from atrial fibrillation. And that's something big release for subsequent complication. Thank you very much.
Thank you, Dr. Nesaruddin Ahmed, for your presentation. Now, as expected, you have a lot of questions to be answered. I think there are a lot of questions for you. So I will select few of them, and I think you can answer few of them. One question is that how MVP can be differentiated from MR clinically? Another question was, what is the differential diagnosis of MR? If it is asked in the exam, what should the examiner answer?
For MVP,
what is the
for MVP, mid-systolic clip, mitral valve prolapse. That's first question. Sir, na?
MVP can be differentiated from MR.
MR usually produce hollow systolic murmur, and MVP is the mid-systolic clip or auscultation. That is the more hallmark for the characteristic hallmark for the diagnosis of mitral valve prolapse. And we can do some maneuver, especially hand grip and squatting. In that case, the murmur intensity may be different variation in the mitral valve prolapse. And mitral regurgitation is produces that is hollow systolic murmur, which radiates toward the back or the axilla. And second question, sir.
Differential diagnosis of MR.
Oh, I have already
what to say in the exam? পরীক্ষা পাস করার জন্য কি বলবে?
পরীক্ষা পাস করার জন্য বি স্পেসিফিক। এখানে থিওরিটিক্যালি কোনো কিছু আনার কোনো প্রয়োজন নাই। যে একটা এমআরআই পেশেন্টের সাধারণত হাইপারডাইনামিক প্রিকর্ডিয়াম থাকে, সিস্টোলিক থ্রিল থাকে, প্যানসিস্টিক মারমার থাকে। আমার প্যানসিস্টিক মারমারের ডিফারেনশিয়াল ডায়াগনোসিস আমি নিয়ে আসবো এখানে। এখানে আমি কি আনতে পারি? আমি এখানে আমি ট্রাইকাসিড রিগার্জিটেশন আসতে পারে, যেহেতু প্যারালাল আমার ট্রাইকাসিড ভালভ। আমি ভেন্ট্রিকুলার সেপ্টাল ডিফেক্ট নিয়ে আসতে পারি। mitral prolapse associated যদি MR থাকে সেটা আমি নিয়ে আসতে পারি। I think and ischemic MR also common, and aortic stenosis sometimes calcified aortic stenosis we can bring differential diagnosis.
আরেকটা প্রশ্ন হচ্ছে differential diagnosis of MR with MS. MR এর সাথে MS থাকলে তার DD কি হতে পারে?
MR এর সাথে যদি MS থাকে সেখানে ASD আসতে পারে। ASD আসতে পারে, ASD common. I think so.
Mechanism of MDM in MR. MDM এর কারণ
that is a flow murmur. Mid-diastolic murmur, flow murmur. It doesn't have any opening snap or systolic accentuation. This is the flow murmur. That is produce relative obstruction. That is produce mid-diastolic murmur. This is flow murmur.
আরেকটা প্রশ্ন আসছে, what is the purpose of dynamic auscultation? Dynamic auscultation করার কি মানে what is the benefit? কি পাওয়া যাবে আমাদের?
আমরা যখন ফ্র্যাঙ্ক auscultation আমরা কোনো ইয়েতে আসতে পারি না, তখন আমরা সাধারণত ডাইনামিক অসকালশনটা আমরা করি। সেখানে আমরা হ্যান্ড গ্রিপ ডিফারেন্ট ম্যানুভার আছে, যেমন রেসপিরেশন হতে পারে, স্কোয়াটিং পজিশন হতে পারে, হ্যান্ড গ্রিপ হতে পারে, ডিফারেন্ট ভালসালভ ম্যানুভার হতে পারে, আর ডিফারেন্ট ফার্মাকোলজিক্যাল এজেন্ট দিয়ে আমরা করতে পারি, অ্যামাইল নাইট্রেট, জেনথিন ডেভিস অ্যাজ ওয়েল।
আচ্ছা, আরেকটা কোশ্চেন আছে, ওইটা মানে পরের স্পিকারের জন্য হবে, একটু ট্রিটমেন্টের ব্যাপারে বলছে যে in case of ischemic MR, is it reversible after PCI? Can it be reversed after revascularization?
I'm not sure, but sometimes it may reversible, but practical life দেখি অনেকে মারমার তো ডিজেপিআর করা থেকেই যায়।
ওকে, থ্যাংক ইউ ভেরি মাচ নেসার, তোমার অনেক প্রশ্ন ছিল, এত প্রশ্ন উত্তর দিলে তোমার সারাদিন লাগবে। বোঝা যাচ্ছে যে তোমার টপিকসটা খুব হট টপিক ছিল আর কি। এনিওয়ে, our next presenter is আমরা ইন্ট্রোডাকশন না দেওয়াই ভালো, is one of the finest echocardiographist in our country. আমরা সবাই তাকে চিনি এক নামে, and he will be presenting the echocardiographic features of mitral regurgitation. Dr. Mohammad Kabiruzzaman, Associate Professor. Kabir bhai, এগিয়ে যান।
Okay, my topics is echocardiographic evaluation of the mitral regurgitation. Respected moderator, my teachers and students, and my dear colleagues. So I will go some few words regarding the mitral regurgitation. This is a normal picture, apical four-chamber view. What is shown here is a zone of coaptation of the mitral valve. This is very important. Is the apical four-chamber view, and this is the same picture, but in parasternal long axis view, showing the zone of coaptation of the normal mitral valve. Here, this part is known as the coaptation height, and this part from annulus to and this red arrow, it indicates the coaptation depth. Actually, for pathogenesis and mechanism of the mitral regurgitation, these two things become disrupted and leads to mitral regurgitation. Now, this is a still picture of mitral valve annular calcification and leading to regurgitation. You know, degenerative mitral valve calcification usually involves the posterior mitral leaflet and the annulus. This is some still picture of cleft AML, and this is the cleft AML with MR, and this is the cleft AML best appreciated in short axis, and this is the three-dimensional echo. Can be very good with better delineation and excellently delineated by 3D echo. Now this is a still picture of, I want to reduce the screen. Okay, this is a diagrammatic picture showing the hypertrophic cardiomyopathy, obstructive cardiomyopathy that leads to systolic anterior motion of the mitral valve. And this is the echocardiographic feature. This is the hugely thickened diabetes, SAM, and the echo picture showing the MR and LVT obstruction. So I'll talk few words regarding the mitral valve prolapse. What does it mean? Mitral valve prolapse occurs as a clinical entity with or without thickening, and with or without MR. Thickening means the thickness more than equal to more than 5 millimeters, and you know the normal thickness is less than 3 millimeters. Now, what is the definition of the mitral valve prolapse? Echocardiographic diagnosis of MVP is usually based on the plaques view and defined as systolic displacement of more than 2 millimeters of one or both leaflets into LA below the plane of the mitral annulus. I'll show the picture. And this is the diagrammatic picture, the plane of mitral annulus, and this is the prolapse of mitral valve. And this is the 2D image. You can see the prolapse. There is the beyond the mitral valve annulus, and this is the MO. It's very helpful in examination, open ask in examination. This is the MVP, posterior displacement of the mitral valve. These are some characteristics of the mitral valve prolapse, mitral valves. This is the spectrum of disease. At one end, there is fibroelastic deficiency. At other end, that is the Barlow disease. And in between the form of frosty. The differences are mainly regarding the thickness of the leaflet and the dilatation or diameter of the annulus. Now, what does it mean by prolapse of the mitral leaflet and flail mitral? The prolapse of the mitral leaflet, there is severe bowing of the leaflet or leaflet segment into LA with the tip of the leaflet still directed towards the ventricular apex. What is by picture? This is the picture of the mitral valve prolapse. The tip, there is prolapse of PML, and the tip of the PML still pointing towards the LV apex. And this is the MR. Now, what is meant by flail mitral leaflet? This usually occurs in caudal rupture, and there is flail segment of the leaflet such that the leaflet is displaced into LA in systole with the tip of the leaflet pointing away from the ventricular apex. What is the picture? This is the flail PML, and the tip of the PML is pointing away from, this is the LV apex, away from the LV apex, and this is the MR. Now, what about the characteristics of the MR in ischemic heart disease? There is abnormal contraction of the papillary muscle or bearing or underlying ventricular wall, and there is characterized by restricted leaflet motion with tethering of the valve, resulting in the appearance of tenting and tethering of the mitral valve in systole that results in MR. What goes by picture is the classical picture. You can see PML is there is tethering of the PML and there is tenting of the AML. And these does cause the non-coaptation, and this is the MR. Now, what does it mean by the functional MR? Here, the normal mitral valve and leaflets and body, there is LV dilatation and dysfunction, abnormal orientation of the papillary muscles and annular dilatation, and causing systolic non-coaptation of leaflet and MR. By picture, this is the diagrammatic. There is dilatation of the LV, spherical remodeling, papillary muscle dysfunction, caudal tethering, restricted leaflet closure, mitral valve annulus, and as well results in the MR. Now, few words regarding the diastolic mitral regurgitation. It's a tricky concept. Actually, whenever there is very increased LV and diastolic pressure, as for example in dilated cardiomyopathy, and a prolonged PR interval that is more than 200 milliseconds, that induces diastolic MR. I will not go details for this. I will skip this lecture. And these are the part of the silent MR. Be sure and be careful. MR not always audible, but like this, the voyage of the wind will be activity that is being talked about it. Two characters of Greek mythology. One is the echo, the symbol of sound, and there is Narcissus, symbol of image. Now I'll go through the echocardiographic assessment of severity of MR. What I have talked previously, that was the etiological diagnosis of the echo. The echo has two-fold. Echo imaging has two-fold. One is to determine the severity of the MR, and another to determine the etiology of the disease. I will talk about now severity. Now, by 2D echo, what are the things we can see? We evaluate the valve morphology and etiology, measure the size of the mitral valve annulus, measure the dimension of the LA and LB, evaluate the size of RA and RB, systolic function of both LB and RB, and observe is there any wall motion and normality of LB or RB. Now, this is the still picture to show the how to measure the LA dimension and end diastolic LV dimension. This is very important for deciding the timing of the surgery. And this is the fourth chamber view, measurement of the mitral valve annulus and the size of the LA. In our institute, we usually take 2 dimensions of the LA size for the surgeons. And this is how to measure the LV ideally. Now, chamber-wise, what is the severity impact on chamber dimensions? For mild MR, chamber dimensions are normal. For moderate MR, LA is dilated, but LV is of normal dimension. Severe MR, both LA and LV is dilated. This is the hemodynamic concept here, and very important. Now you can see the mitral valve in rheumatic heart disease, how the coaptation depth and height reduced. You can see the signal. The PML, both leaflets are thickened, PML is immobile, and there is non-coaptation central part, and there is decreased in the coaptation height both. The same patients in apical 4th chamber view. What does it mean? There is severe MR. This is the wall impinging MR jet and swells in the inside the LA cavity. Both LA and LV are dilated. So this is the classical scenario of severe MR. Now, what does it look like the flail AML? You can see it. There is AML is flail AML. So there is a vegetation attached to the tip of the AML. How does it look like? You can see this is the vegetation. Now we can see the prolapse of the AML of 65 years old male. See, this is a very good picture, good scenario to see the prolapse of AML. Now, M mode. how can it helps us to diagnose the prolapse? This M mode of echo can be applied for evaluation of MVP and to evaluate the systolic anterior motion of the mitral valve in case of hypertrophic obstructive cardiomyopathy. How does it look like? This is the plan of the mitral valve in 2D, and this is the M mode, that is posterior displacement of the mitral valve. But be sure your M mode cursor or beam should be just beyond the mitral valve annulus. There are 4 pictures. One is the normal picture, another is the MVP. As I have shown previously, there is posterior displacement of the mitral valve, and this is the picture of the HOCM, hypertrophic obstructive cardiomyopathy with some. There is anterior displacement, systolic anterior displacement, and you can gauge it easily by systole, and this is the systole. And this is the color mode. So how we can differentiate the pan-systolic murmur and a late systolic murmur. This is the example of the pan-systolic murmur, and this is the example of the late systolic murmur. You can see the systole and the late systole. This is the pan-systolic murmur. This is the murmur. Pan-systolic murmur. Pan-systolic mitral regurgitation. So Doppler echo. Now we'll see what are the parameters we can estimate or evaluate the Doppler echo. One is the MRZ area and its nature, measurement of the vena contractor width, volumetric method for calculation of the mitral regurgitation volume. We can estimate the proximal isovelocity surface area, and we can measure the PA pressure. And this is the schematic or diagrammatic representation. Whenever one is to get the ECG, what is the extent of the mitral regurgitation? It starts from the beginning of the R wave and ends after the end of the P wave. This is the MRZ. And this is the still picture of the MR, and still with the, you can correlate with ECG. Now, J area method of the mitral regurgitation. How can it be done? So you can have it classically, we do it the 4-chamber view and trace the MRZ, have another area, and you can have 2 views, 4-chamber and 2-chamber, then can average. Then how can it be assessed severity? The MRZ regurgitation Z area and the left atrial area ratio is then calculated. And MR is graded as follows: less than 20% MRZ size is mild MR, and more than 40% of the LA, it is the severe MR. Now this is another method for grading. Someone, if at the jet area, when it is 15% grade 1, 25% grade 2, 35% grade 3, 60% grade 4. Now, regarding the vena contractor method of MRZ, this is very important. It's practically applied. So, the most practical initial method to assess the severity of the mitral regurgitation, the vena contractor is affected less by the eccentricity of the MRZ. So, it is this advantage, and have an advantage over the PISA method for eccentric regurgitant jet. How can it be done? Optimize color flow imaging of regurgitant jet by demonstrating the PISA, vena contractor, and regurgitant jet. This is important. And magnify the region of interest with zoom, then measure the smallest void immediately distal to the regurgitant orifice, perpendicular to the direction of the jet. How it looks like? So this is the classical example. The zoom view, apical 4-chamber view, you can see the PISA, the neck, vena contractor, and the whole length of the MR. And this is the ideal point for measurement of the vena contractor perpendicular to the jet of the length of the MRZ. These are 3 other examples how to measure the vena contractor. Now, vena contractor width method, how does it mean mild, moderate, severe? Less than 0.3, vena contractor is mild, and more than 7, it is a severe MR. Now, how to evaluate the mitral regurgitant volume, regurgitant fraction, effective regurgitant orifice area? These are 3 key concepts, and more or less academic interest, not practice in our day-to-day real life. So I'll not go details for this to bombard your thinking. I'll skip all the regurgitant volume, fraction, orifice area. can be measured by two methods, volumetric methods and PISA method. But I will not go details for this. So I will skip these slides. Just have a glimpse, like the glimpses of the world history of the Nehru. How do these things like so? So, but I'll show you the severity of these parameters. Regurgitant volume, when it is less than 30 ml, it is mild. When it is more than 60 ml, it is severe. For regarding the regurgitant orifice area, where it is less than 2, it is mild. More than 4.4, it is severe. It is already been talked by Dr. Ishraquzzaman, so I will not go details. Now to calculate the PSP, pulmonary pressure, how can I do this? Just find out an TRJ and put the continuous Doppler and trace like that and find out the peak gradient. Here peak gradient is 105 and add the RA pressure with it. Usually we add 10, then PSP will be at 115. Very high TA pressure, severe pulmonary hypertension. This slide. Now this is the algorithm. How can we proceed in Doppler wise to decide about the MR severity? If put the colored Doppler, if it appears more than mild, then measure the vena contractor. If it is more than 0.7, severe MR. If it is less than 7, then it is mild MR. And then you can measure the jet width and jet area like this. And other methods are PISA and the pulse rate Doppler volumetric method, but I will not go details for this. Now come to the LV size and systolic function. This is a very important part for deciding the timing of the surgery. And this is the primary focus on serial studies in patients with chronic MR as a key element in clinical decision making. For mitral regurgitation, MRJ, severe MR, normal LV function is the more than 60% LVEF is the normal function. Anything that is just below the 60%, it is abnormal systolic function. So, what are the parameters for LV dysfunction? It is the evidence of progressive LV dilatation and the end systolic dimension more than 40 to 45. I have mentioned the two figures. More than 40, it is mentioned in ACCR guideline, and more than 50, it is mentioned in the ESC guideline, or any reduction in LV systolic function. And you can should prompt consideration of surgical intervention, regardless of the symptomatic status of patient, to prevent irreversible LV dysfunction. Now, strain evaluation. Strain, anything just less than minus 19.9 indicate that the LVEF corresponds to the less than 50%. So it's an important tool for deciding the timing of the surgery. Transesophageal echo, where it is better option in case of poor transthoracic echo window and go for good understanding of the mechanism of MR and routinely used in the power operative evaluation for mitral here. Now, stress echo, there's already Dr. Nesaruddin have talked about it, so I'll not go to this. Now, these are some the slides about it. Now, decide about the severity of the mitral valve. You have all the parameters. The slides are automatic. You can, now you can decide two methods for severity. One is the mild, moderate, and severe. This school of thought. Another is stages. But in our real life, we usually practice these methods: mild, moderate, severe. But for staging, as a details by me, Ishraquzzaman, I will emphasize two things. There is 2 points: asymptomatic severe and symptomatic severe. Severe lesion may have but the patient is remaining in asymptomatic status, and so severity, mild, moderate, severe, these are echocardiographic diagnoses. The patient may or may not be symptomatic, and that needs the clinical correlation. And these are all parameters that I have talked with individual parameters with jet area, vena contractor like this. So I will not go details this. I am at the end of my lecture. I will talk few words regarding the secondary MR. It is a greater difficulty defining the severity of the MR in patients with secondary MR than those of the primary MR. How does, you can see there are several parameters. But I will emphasize two parameters, regurgitant volume and effective regurgitant volume. For primary MR, it is the more than 60 ml that is severe. But for secondary MR, only the 30 ml that indicates severe MR. And for effective regurgitant orifice area, for primary MR, it is the more than 0.4 that indicates severe. But secondary MR, only 0.2, more than 0.2 that indicates severe MR. So this is my very favorite slide. Wisdom implies the timely and rightful application of knowledge. And thank you all for your patience here.
Thank you, Dr. Kabiruzzaman, for your excellent lecture. So now our last presenter is Dr. Professor Nazir Ahmed. He will be talking about the treatment modalities of mitral regurgitation. Professor Nazir Ahmed, please go for it. Share question. আচ্ছা তার আগে একটা question, just a few minutes. I can want to talk with Dr. Kabiruzzaman. Are you listening to me?
Okay, I'm listening.
আপনার you have a few questions for you. তার মধ্যে একটা হচ্ছে যে how differentiate ischemic MR from rheumatic MR through echo. I think এটা আপনি বলেছেন already. Differentiation between ischemic MR and rheumatic MR by echocardiography. আর সেকেন্ড কোশ্চেন হচ্ছে what is the role of stress echo in my MR? এই দুটো কোশ্চেন আনসার দিয়ে আমরা তারপর নাজির ভাই
Stress echo in
MR.
Actually, whenever there is confusion or disparity between the symptom and the echocardiographic parameters, then usually we go for the stress echo. Whether after stress there is severity, there is increase in severity of MR, and the patient becomes symptomatic. That is the main issue.
আর আরেকটা ছিল যে differentiate between ischemic MR and rheumatic MR by echocardiography.
Very clear, very clean cut. In ischemic MR, this is secondary MR, leaflets morphology are within normal limit. But for rheumatic heart disease, the valve leaflets are thickened. And classically, the PML is immobile. There is thickening of the leaflet, and there is thickening of the subvalvular structure, and there is more or less fusion of the commissures. One thing that I want to get attention that for mitral regurgitation, there is predominantly contracture of the effect of the subvalvular structure, that is chording. And for mitral stenosis, there is predominant fusion of the commissure. That makes the difference.
আচ্ছা আরেকটা প্রশ্ন হচ্ছে এটা হচ্ছে vena contractor নিয়ে. Can vena contractor method correctly classify MR in a patient with LV dysfunction?
Actually, for LV dysfunction, there are some fallacy. Because there are systolic dysfunction, so MRJ is not that smart like in primary MR. So it will be decided on the different parameter. That's why for severity of secondary MR, there are some parameters that is much less reduced or than the primary MR. I have shown it.
আচ্ছা আরেকটা প্রশ্ন হচ্ছে in the case of eccentric MR, how we will assess severity in echo?
Eccentric MR is a tricky MR. If you see that there is eccentric wall impinging and swells inside the LA cavity, it's an indication of the severe MR. Another thing, if you find that the LV dimension is direct, then it is severe.
Okay, thank you very much, Dr. Kabiruzzaman. We had more questions, but okay, we'll go for Dr. Professor Nazir Ahmed for his presentation.
Hello, everyone. Good evening. I'm talking about my management of mitral regurgitation. Shona jai?
শোনা যাচ্ছে
Sir.
Mitral regurgitation, that is the medical management and interventions. Management of mitral regurgitation, it has three components. That is the medical treatments, either surgery or repair of the mitral valves, or sometimes minimally invasive procedures, percutaneous or surgical procedures. Acute mitral regurgitation is always very medical emergency. acute myocardial regurgitation is a medical emergency, especially in acute severe MI. It occurs, most of the patient is acute myocardial infarction, infective endocarditis, traumatic, or myxometastasis, stressful condition, and several other symptoms where the chorda or papillary muscles are dysfunctions. And regarding treatments, early diagnosis and treatment is needed as soon as possible. And medical therapy has limited role. And that's why sometimes vasodilator therapy is very much helpful. Combination of therapy, that is inotropic agent, especially dobutamine and nitroprusides, sometimes given some beneficial effect. Regarding IABP reduces the afterloads. Sometimes it requires for the bridging for mitral valve surgery. Percutaneous circularity assisted device might help to stabilize the patients. And in acute mitral regurgitation, if it is due to the pulmonary edema or something, some medical treatment is required. That is the beta blocker, ACE inhibitors, and nitrates and vasodilators also. And regarding treatment of acute mitral regurgitation, there is the intervention is the best options. It means prompt mitral valve replacement is the recommendation for severe acute mitral regurgitation. But in case of chordal ruptures and mitral valve repair is better option than that of the mitral valve replacement. In case of mitral regurgitation, selective use of mitral clips in post-infarct patients is reported recently. Regarding chronic primary mitral regurgitations, we know the chronic mitral regurgitation divided in two groups we have seen earlier, that is primary and secondary. I am talking about the primary mitral regurgitations is management. The role of medical therapy for asymptomatic and chronic MR caused by valve disease is not well established. ACCN, AHA, and European Society of Cardiology guidelines do not recommend the use of pharmacological vasodilators in chronic mitral regurgitation with preserved LV functions. And some drugs are very important, especially beta blockers, diuretics, ACE inhibitors, ARB, aldosterone antagonists, and prophylaxis for infective endocarditis and anticoagulation if there is any atrial fibrillations. Sometimes very arrhythmia is found to control the arrhythmias. Regarding management of the chronic mitral MR, surgery is the best option. Valve replacement number one. If possible, that mitral repair is the best option than that of the mitral valve replacement. Sometimes minimally invasive surgical procedure is very important for surgery of the primary mitral regurgitations. Regarding management of secondary mitral regurgitations, it is also functional mitral regurgitations. It means the valves are normal, but problems in the heart muscles. That means heart muscle makes the valves problematic. And medical management is that the patient with secondary mitral regurgitation and heart failure with reduced LV ejection fraction should standard guideline directed medical therapy for heart failure, including ACE inhibitors, ARBs, beta blockers, aldosterone, and CRT with biventricular pacing is very recommended for secondary mitral regurgitations. And lifestyle modification is another important issue, and also the anticoagulation in atrial fibrillations. Regarding guidelines for surgical guidelines for mitral regurgitations. These are the guidelines. It is 2017. It is overlapped with the 2014. There is the indications, interventions of recommendations is this. The chronic primary MR. I'll give you later details. And the next one is secondary MR. There is this one. And guidelines. Sometimes what guidelines do not provide. All guidelines do not provide because it does not cover all different combinations of conditions. Number two, it does not include the individual experience, and also it does not include the economic factors in different countries, in different situations, and newest advancements always usually not indicated in guidelines. Regarding indication of surgery for mitral regurgitation, this is very important issue. Here, the mitral regurgitation is here, it divided in primary mitral regurgitation and secondary mitral regurgitation. We are talking about the primary mitral regurgitation. It means problems in the valve which leads to disease in the heart is divided in two ways. That is, one is severe mitral regurgitation when the vena contracta is more than 7.7 and LV is volume is more than 60 and etc. and LV dilated. All of these, is when it is symptomatic. That is the ejection fraction is more than 30. Surgery is number one options. That is the ACC guidelines say. But when ejection fraction is less than 30, is surgery. Sometimes it is 2B. Is another one we can see when it is asymptomatic patients. It is very important. Patient is asymptomatic, but ejection fraction is in between 30 to 60, and LV ejection systolic diameter is more than 40, and in these cases, surgery is the best option. Regarding another way, ejection fraction is more than 60, and in systolic diameter is less than 40. If it is progressive disease, there is decreases the ejection fractions, and there is the surgery is the option class 2A. But when the ejection fraction is the more than 60, will be in systolic diameter is less than 40. Likelihood repairment is the best option. If it is possible, then mitral valve repair is doing. If it is not possible, then only follow up periodically. Another one is say the progressive mitral regurgitations. And some vena cava contrast already it is previously mentioned, and only follow-up is the best option periodically. Regarding secondary mitral regurgitations, there is problems in the hearts, not in the valves. It is due to either coronary artery disease and heart failures and condition CRT in these patients. When treatment of coronary artery disease, heart failure, and sometimes we do synchronized therapy. Then if it is symptomatic still and severe MR, in this case, when persistent NYS class 3 or 4, surgery is the option, especially in the secondary mitral regurgitation. But when it is asymptomatic with severe mitral regurgitation, patient is still good. NYS classification is less than that of the 3 or that periodic treatment is the best option. Follow up. Another progressive MR That is the stage B, it is earlier mentioned only, that is the follow-up is the best options. This is the when we intervene regarding mitral valve treatments. According to the guidelines, indications for surgery, especially mitral valve replacement in chronic primary mitral regurgitation, is when mitral valve surgery is recommended for symptomatic patients with chronic primary MR, that is stage D, and with ejection fraction is greater than 30. That is the class 1 indication. That is the replacement of the mitral valves. Another one, mitral valve surgery is recommended as a asymptomatic patients with chronic mitral regurgitation with mild to moderate LV dysfunction. That is the ejection fraction in between 30 to 65 with an LV end systolic diameter 40. That is the class 1. It is still surgery is the best option, especially mitral valve replacement. But sometimes in between these two, concomitant mitral valve repair or mitral valve regurgitation replacement is indicated in patients with chronic primary mitral regurgitation undergoing cardiac surgery for either indications. Here we can see in number 1 when mitral valve replacement is needed. When it is very smooth, in very small simple way, surgery if patient is symptomatic, when it is more than 30% ejection fraction, surgery is the number 1 options. Second, why not less than 30% surgery will be the best option? Because less than 30% ejection fraction, no surgical, no survival benefit, higher mortality rate, and high recurrence of mitral regurgitations. And that's why ejection fraction less than 30 is not a very good enough condition for the patients. Next one is same, that is the class 1 indication, that is the recommendations, where that is the severe mitral regurgitations with mild to moderate LV dysfunction, that is 35 to 60, and LV end systolic is 40. It is same very small way we can say asymptomatic patient with ejection fraction less than 60 and end diastolic diameter is 40 or 45%. Surgery is the best option in this sense. It is same we have mentioned in earlier. What are the types of mitral valves we use in mitral valve replacement? That is the mechanical valves and tissue valves, tilting, bileaflet, and caged ball valves sometimes, and tissue valves. It's different types of tissue we are using. Indication of mitral valve repair in chronic primary mitral regurgitations. Here, that is the mitral valve repair is recommended in preference to mitral valve replacement when treatment is indicated for patient with chronic severe primary mitral regurgitation with involvement in the posterior leaflets of the mitral valves. That is the class 1 indications. Mitral valve repair is recommended in reference to mitral valve in preference to mitral valve replacement when treatment is indicated with patient is chronic severe mitral regurgitation, involvement in the anterior mitral leaflets or sometimes both the anterior and posterior lateral leaflets, and with successful repairment is very important regarding repair. And mitral valve repair is reasonable in experienced surgical centers for asymptomatic patients with chronic severe mitral regurgitations and where preserved LV functions and new onset of atrial fibrillation, pulmonary hypertension, PSP more than 55, and while likely to successful repair it is about 95%, and mortality is less than 1%. That is the class 2A indications. This is the rule of thumb is that repair is always better than the mitral valve replacements. And why? Mitral valve repair is the best because it lowered operative mortality than that of the mitral valve replacement. LV function is preserved, left thromboembolic manifestations, less anticoagulants induced hemorrhage is very important, but it has got some problems. Problems are when the anterior leaflets were difficult to repair when extensive calcification and associated with other diseases. Commissure area is our extensive disease in both the commissions, and middle scapula of posterior leaflets having severe diseases, more coaptation distance, and complex jet of the mitral regurgitations. In nutshell, we can say the management of severe chronic mitral regurgitations is divided in two ways. We previously mentioned, that is number one is when the patient is symptomatic, ejection fraction is more than 30%, direct surgery or repairment is the best option. When it is less than 30, and refractory medical management is okay, only medical treatment is go. It's not possible, repairment or with other morbidities, surgery is another options. When it is not possible for surgery, then treatment with medical management, sometimes percutaneous, edge-to-edge repair. Regarding another one, when LV ejection fraction is less than 60, LV systolic is 45, we already mentioned it, surgery is the options. New onset atrial fibrillation and PSP is more than 50, and surgery repair is the options. When is likelihood where repair or surgical low risks and presence of risk factors, there is the surgery sometimes is very important. When it is not possible, follow-up is the treatment. This is the secondary mitral regurgitations. It is also guidelines has shown that the secondary mitral regurgitation treatment in the coronary artery disease, heart failure, and consider CRT is the best option. And if it is still symptomatic with severe MR, persistent echo, the surgery is the best option. And other two, asymptomatic patient severe MR, patient is LV function is preserved, that in periodic management, and progressive MR, but LV is good, that is periodic monitoring is very important. Regarding secondary MR, if the bypass surgery is indicated with ejection fraction is 30% or more, surgery with MBR is the options. Another options, whether bypass surgery is needed when but ejection fraction is less than 30%, but evidence of viability of the myocardial infarction, there is a chance of improvement of the LV functions. In these cases, we do CABG, either mitral valve replacement or repair. And as another some issues, that is percutaneous interventions for mitral valve regurgitations. Sometimes we use when mitral valve clip we can use. Mitral valve clip is a transcatheter mitral valve device for use of the high risk inoperable patients with severe mitral regurgitation suitable anatomic criteria. It is currently approved by US FDA for use in symptomatic patients with primary, that is the degenerative patients who are prohibitively with surgery. In contrast, mitral clip system has already received class 2B recommendation by PAC guidelines. Another option is percutaneous, that is the S to S repair for mitral regurgitations. It can be done percutaneously, sometimes it's by surgery. But in case of treatment, S to S repair, it is inferior to surgery to reduce the mitral regurgitation, improves the symptoms, improves the quality of lives, and improves the functional capacity. It has got some criteria for S to S repairs, that the moderate to severe and coaptation lengths and etc. is there. Another option is robotic mitral valve repairs. It is still doing from the percutaneous procedures. It is going the from the behind the right atrium into the LA, and it is done by mitral repair in this way. Regarding mitral valve prolapse management, a normal lifestyle and regular exercise are encouraged. A restriction for competitive sports, patient with mitral valve prolapse, palpitation, chest pain, anxiety, beta blocker is the best option. Cessation of stimulants such as caffeine, alcohol, cigarettes should be avoided. In mitral valve prolapse another management, the class 1 indications, in this case, aspirin is the best option. Patient with mitral valve prolapse with experiences cerebral transient ischemic attack. In patient with mitral valve prolapse, atrial fibrillation, warfarin is recommended in patients age greater than 65 or those with hypertension, mitral MR, murmur, and history of heart failure. Another is aspirin, that is 75 to 325 per day, is recommended in patients with mitral valve prolapse and atrial fibrillations who are less than 65 years old and have no history of mitral regurgitation, hypertension, or heart failure. In patients with mitral valve prolapse and a history of stroke, warfarin is recommended in patients with MR, atrial fibrillation, or left atrial thrombus. Class 2 indications. Patients with mitral valve prolapse, history of stroke, aspirin therapy is reasonable. Patients who do not have MR, atrial fibrillation, LA thrombus, and echographic evidence of thickened mitral leaflet 5 millimeters or more. Warfarin therapy is reasonable for patients with mitral valve prolapse with transient ischemic attack despite aspirin. Aspirin therapy is beneficial in patients with mitral valve prolapse, history of stroke, who have contraindicated to anticoagulants. Aspirin, therefore, therapy may be considered in patients with abnormal rhythms, echocardiographic evidence of the high risk of mitral valve prolapse. That is the class 2B. Thank you all. শোনা যায়?
হ্যাঁ, শোনা যাচ্ছে। Thank you, Dr. Professor Nazir Ahmed, for your elaborate lecture. So you have few questions. কয়টা প্রশ্ন আছে আপনার জন্য? If you can answer those questions. Number one, one question is asymptomatic patient with severe MR. এদের ইন্ডিকেশন অফ সার্জারি কি হবে? এক। আরেকটা প্রশ্ন হচ্ছে যে এই প্রশ্নের উত্তর দেন, তারপরে প্রশ্ন হচ্ছে যে asymptomatic patient severe MR.
Already it is mentioned in the guidelines. It is found that asymptomatic patients, good LV functions, with mild to moderate MR, especially moderate MR, is LV function is normal or some preserved of the LV functions, only follow-up of the patients with some medicine for mitral regurgitations. Follow-up may be done annually or 2 years intervals. If the mitral regurgitation is relatively higher, that is moderate to severe in these cases, when the LVD systolic function is gradually down with severe, sometimes with severe mitral regurgitations, then surgery is the options.
আচ্ছা, আর ডক্টর কবিরুজ্জামান, আপনার কাছে কটা প্রশ্ন ছিল, এটা পরে আবার প্রশ্ন আসছে, আপনি আছেন লাইনে? কবিরুজ্জামান,
হ্যাঁ,
প্রশ্ন হচ্ছে যে বলছে যে এলভি আইডিডি এবং এলভি আইডিএস, এটা শুড আই এক্সপ্রেস বাই মিলিমিটার ডাইরেক্টলি অর মিলিমিটার per square meter of body surface area, which is more specific? So definitely, I think more specific is body surface area. Definitely, কোনো সন্দেহ নাই। এই প্রশ্ন করেছে আর বলেছে যে পেশেন্ট উইথ, লিখে দিচ্ছে, দিস কোশ্চেন ইজ ফর কবিরুজ্জামান স্যার। আচ্ছা, পেশেন্ট উইথ মডারেট এমআর এন্ড মডারেট এআর সিম্পটোমেটিক হলে অপশন কি দিবেন?
Actually, moderate AR and moderate MR, if there is hemodynamic burden, because both the lesions lead to an volume overload to LV, and if there is LV dilatation and dysfunction, patient is symptomatic, then you have to go for surgery.
Achha, ঠিক আছে। Okay, thank you very much to all the speakers, and thank you all the audience and the participants who have participated so long with us. And we have got two eminent professors with us on the audience. I want to request them both to have their comments. Professor Abdul Wadud Chaudhary, he is online, and Professor Fazilatussana Malik. So I request.
আসলে আমি দেখছিলাম তো তিনটে কমেন্ট করব আমি। একটা হলো অনেক ডিটেইলে আলোচনা করা হয়েছে। এখন আমাদের কিন্তু যখন এরকম আমরা এই যে লেকচারগুলো আয়োজন করি, আমাদের তিনটি জিনিস খেয়াল করা উচিত। কাদের জন্য করছি, কেন করছি, এবং তারা কি এটা গ্রহণ করতে পারবে কিনা। যদি আমি পরীক্ষার পার্সপেক্টিভে বলি, দ্য বেস্ট লেকচার ওয়াজ গিভেন বাই প্রফেসর কাবিরুজ্জামান। একদম টু দি পয়েন্ট, আমার এইটুকু জানা দরকার, এটার জন্য এটা। আচ্ছা, নাজির ভাইয়ের সাবজেক্টটা যেটা, সেটা আসলে খুবই একটা কি বলবো আমি, যে উনার এটা আছে অনেক কাম্বারসাম। ব্যাপারটা আসলে যে দিস ইজ এ মেকানিক্যাল প্রবলেম, ইউ হ্যাভ টু গো ফর মেকানিক্যাল সলিউশন। তাতে আমাকে গাইডলাইনের কথাটা আসবে। আমি আসলে প্রেফার করবো যে আমরা গাইডলাইনগুলো দেখি, জাস্ট গাইডলাইনটা দেখে আমি সরে গিয়ে জাস্ট আমার কি পয়েন্টটা, যে একটা দুইটা তিনটা এই কি পয়েন্ট আমার খেয়াল রাখতে হবে। আমার স্টুডেন্ট তো পরীক্ষার হলে বা আমি যখন তাকে জিজ্ঞেস করবো অতটা বলতে পারবে না, যে তাদের জন্য এটা হলে ভালো হতো। ইশরাকের জন্য ভাই আমি এটাই অনুরোধ করবো, তুমি গাইডলাইনটা দেখাও, দেখি গবে গিয়ে তাকে জাস্ট কি পয়েন্ট, দুইটা তিনটা চারটা পয়েন্ট বলে, এর বেশি বলো না, কারণ দে ওন্ট রিমেম্বার, এটা লাভ হবে না। এটা নেসারের এটা কিন্তু আসলে ভালো করছিল, কিন্তু এটা আমাদের বুঝতে খুব অসুবিধা হলো, কারণ তার ওই যে ইন্টারাপশন হচ্ছিল, সমস্যা ছিল। একটা খুব চোখে পড়ার মতো জিনিস হলো, প্রত্যেকটা প্রেজেন্টার খুব মানে হোল হার্টেডলি পরিশ্রম করে প্রেজেন্টেশন গুলো তৈরি করছেন। এজ এ টিচার আই রিয়েলি থ্যাংক দেম। মানে এটা তারা যে কষ্ট করে করছেন এবং এটা যে কত সুন্দর করে করছেন সেটা দেখলে বোঝা যায়। এবং আমি ইয়েকে বলবো যে স্টুডেন্টদের যেটা বলবো, তারা অনেক কিছু চমৎকার চমৎকার কোশ্চেন করেছে এবং দোজ আর ভেরি ইম্পর্টেন্ট। আমার মনে হয় সেটা খুব চোখে পড়ার মতো। এই আমার কমেন্টটা আমার ভালো লাগছে। আমি আজকে কিন্তু আমি ঝামেলার মধ্যে অনেক ইয়ে করে বসছিলাম।
Thank you, Dr. Wadud, for your excellent comment. And now I request Professor Fazilatussana Malik to have some comments on this.
Well, I wasn't prepared to give any. I was sitting in the veranda watching this thing. So thank you so much, everyone. I really had a great time. I learned such a lot, as usual. And I think everyone was really good. And first of all, I think I would like to thank Wadud for coming over. Thank you so much, Wadud, for coming and giving us inspiration. That means a lot to us. Thank you so much.
Okay, thank you. Thank you all to all the participants and the speakers. And we'll see you again in the next 1st of July. And our topics will be aortic stenosis. Till then, goodbye, good luck. Thank you very much. Goodbye.
Thank you.